I'd like to have your attention, please. We'll start with the second plenary session. The layout of this session is that we have two distinguished speakers. But before we start the program, I would like to call Professor Saeed Qureshi, Dr. Aamir, and Dr. Salman Keshavjee to please come and take their seats. Anyway. Our chair of the session is Dr. Saeed Qureshi. He is the Vice-Chancellor at Dow Health University and Professor of Surgery. I would like to start with the first speaker, Dr. Salman Keshavjee. He is Associate Professor of Global Health and Social Medicine at the Harvard Medical School, and also Associate Professor of Medicine at the Brigham Women's Hospital. Dr. Keshavjee is a leading expert in drug-resistant tuberculosis treatment and the anthropology of health policy. I would like to request Dr. Salman Keshavjee to come and give his talk. Thank you.
Thank you very much. I'd like to thank the organizers for inviting me to join today's session. It's an amazing honor to be here as part of Indus's conference, because I'm going to talk about tuberculosis. That's the disease that I've spent a number of years working on, and TB is actually the quintessential disease of poverty, but it's also very paradigmatic of the way we've treated global health over the last 60 or 70 years. Do I need to do something to get my slides on the screen? I'm guessing press this button. That did it. Okay. So I want to just give everyone some background on TB, because I realize that people here are a mixed audience and not everyone knows a lot about TB. So every year, and if you look at the statistics over the last 20 or 30 years, every year you see that there's about 10.4 million cases of TB annually. And every year for the last 10 or 15 years, we only find about 60% of those cases. And we miss a significant number of people with drug-resistant TB, 600,000 people. And of that group, we treat a very small amount. 80% actually go untreated. And for those that get treated, they actually, only half of them get cured. There's about 1 million kids that get TB every year, and we find about 1/3 of them. So 670,000 roughly children every year presumably die from the disease. And we also have about 2 million deaths annually from TB. So I'm trying to forward the slides, but they're not moving. Okay. So if you look at rates of TB dropping over the years, the rates drop about 1.5% per annum. And that's been the case since the early 1990s. That means that TB actually, the rates are roughly the same globally. It hasn't dropped that much. It's the biggest infectious killer of adults worldwide. In fact, it's overtaken HIV as being the biggest infectious killer of adults. And it's actually the biggest killer of people living with HIV. Now, why should one care about TB? And I'm going to give you a couple of reasons to think about this. Some anthropological and some, as far as just the risk that patients face. Let's start with the risk. TB patients are at very high risk of dying. So if you have TB disease, your risk of dying from drug-susceptible disease in countries, in poorer countries, is about 10%. So if you're diagnosed and treated, your risk of dying is about 10%. If you have drug-resistant TB, your risk of dying, even if you're treated, is 50%. So we know that only 60% of the people with drug-susceptible TB are found, and we know that only 20% of the people with MDR TB are found. But even if you're found, your risk of dying is extremely high. So since only 20% of the MDR-TB patients are diagnosed or treated, the actual risk of dying from that is 75%. If you have more advanced forms of TB, like extensively drug-resistant TB, XDR-TB, your risk of dying, if you've been treated, is 80%, but really only 10% of the people are diagnosed, so your risk of dying is 98%. So when you start to compare that to, say, some different types of cancers, just because it's easy to compare that to, your risk of dying from breast cancer is 1 to 5%. Your risk of dying from lung cancer within 5 years of diagnosis and treatment is about 45%. And your risk of dying from pancreatic cancer within 5 years of diagnosis and treatment is 93%. So people who are facing TB have a much, much higher risk of dying, as you can see, or an equivalent risk of dying. Now, as you know, this disease is treatable. It doesn't have to be that way. But let's just suppose that this was this is the risk. Now, some people get infected with TB and they don't actually get active disease. They stay infected, and about 10% of those people will get active disease when they, half of them within the 2 years after infection, and half later on in their lives. So when you think about it, it's a big number that's going to have active disease. So if you have, if each TB patient infects about 10 people, and 1 in 10 people will get the disease, if there's about 10 million cases a year, that means 40 million people get infected every year, right? 10% are going to get active disease that was preventable. So that's crazy. That's a very big number. So 4 million people will get active disease that was preventable. Now let's just do some math here. If 10% of those with active drug-sensitive disease die, it means that if you don't, and you don't have to do the math, I'll tell you the answer. If you're a contact of a drug-sensitive TB person, you're just a contact. You happen to live in the same household, your risk of dying is 1%. So it's a very big killer. And if you're a household contact of a drug-resistant patient, your risk of dying is 7.5%, just being a contact. So this week, I visited a local hospital where a doctor told me it's completely unnecessary to treat drug-resistant contacts. The risk of dying from that is 7.5%. So really, really a major problem. So when you start to look at TB, you realize that it's an interesting medical disease, but it's really the paradigm for the justice gap in global health. And the reason is because we know that we've had a cure for TB for more than 70 years. So the first drug to treat TB, streptomycin, was discovered in 1943. This is a picture of Salman Waxman, in whose lab it was discovered. And it was given to the first human in 1944, and it went through clinical trials and started being used in 1948. So here was a drug that essentially killed the bacilli, and then very soon after, a number of other drugs were invented. I mean, so many people died of TB in the 19th century that in the 20th century, when drug discovery started, there was a big focus on getting rid of TB. And I want to just delve a little bit into the science of it, because I want us to realize why it's paradigmatic. We had all these drugs, and very early on, the British Medical Research Council did a number of fantastic trials. They took streptomycin and they gave it to people, and when they gave only streptomycin, they realized that they would get resistance. If they gave it with one of the other drugs that were made, they wouldn't get resistance. And the same thing happened when the new drugs like isoniazid came up. And so they realized that drug resistance emerged with every new drug you used, unless you did it in combination. So you needed to give combination chemotherapy. That was known very, very early on, in the very early 50s. In the very early 50s, the Medical Research Council of the UK conducted a drug resistance survey in Britain just a few years after the new drugs were actually made. And they found out that there was primary drug resistance to the new drugs themselves. Primary meaning that the patients just arrived, they had never been treated before, and they had resistance, which means that they had been infected by a resistant strain. So as early as 1955, people knew that if you had strains that were not treated, they would be transmitted even if they were drug resistant. Johns Hopkins University, Richard Riley, did a number of experiments that he showed that if you don't treat people, He took the air from the room that patients live in, and he circulated it into a guinea pig chamber, and he showed that if you don't, and guinea pigs are very sensitive to TB. He showed that if you don't treat the patients, 100% of the guinea pigs get infected. If you start the patients on treatment, even for 24 hours, it turns out that almost none of the guinea pigs get infected. So very early on, people knew that you had to get people on treatment right away. And then the United States had a major problem in Alaska with TB, in a town called in Western Alaska. And they did a study in a town called Bethel, a region called Bethel, around this town that was very poor, where people had a lot of malnutrition, a lot of overcrowding, living in close quarters because of the weather and other reasons. And the TB rates there were 2,000 per 100,000. And so huge, it was like a prison, prison systems in many parts of the world have rates that high. And so they built hospitals, and they saw some decline in the TB rate, and you can see that it kind of drops around 1950 to 1952, 53. Then they started a community-based program. They went and treated people in their houses. They screened them. They gave them treatment at home, and they saw a drop, but not what they expected. And they realized that people were somehow they thought they'd screened everybody, but then somebody would come in with TB again. And they realized that what they referred to as some sort of quiescent phase of the bug, what we call so-called latent TB today. And so they started treating latent TB with isoniazid, and the rates of TB dropped from 2,000 to 146 in 5 years. So they put out this study in 1960. So by 1960, we actually knew that you couldn't stop an epidemic by just treating the active cases. You actually had to treat the household contacts. Just basic science that we knew by 1960. And so all of this was kind of put together, and there were some basic principles of epidemic control, that you had to search for infected people amongst the contacts, you had to start therapy quickly, giving safe multi-drug therapy. You had to, of course, ensure that people took the therapy, and you had to treat all contacts that didn't have the disease. Really simple stuff. Countries in the West took this paradigm, and they actually treated TB. And of course, the rates dropped. And by 1970, most Western countries had almost no TB. This is what happened in Alaska. And later in the 1980s, New York had an outbreak where rates of TB had gone up to 200 per 100,000 in places like Harlem, and they did exactly the same thing. They treated it. So why haven't we been able to stop the epidemic globally, right? If we've known this since 1960. Well, it turns out that I think it's a complex story, and since I've been warned by Aamir not to go over time, I'm going to keep it simple. But I think it really it's linked to the colonial legacy, and it's linked to an economic movement called neoliberalism that came into play in the latter part of the 20th century. But remember, when the World Health Organization started after the creation of the UN, the idea was to really they called it the World Health Organization because the idea was to stop thinking about international borders, start thinking about people. Prior to that, the League of Nations, the precursor to the WHO, had a hygiene section in Geneva. And their main concern was to prevent diseases coming from the colonial periphery to the colonial centers. So stopping cholera, etc. That was their main worries. When the WHO was created, it actually moved into the same offices as the League of Nations hygiene section and had exactly the same staff. So, the colonial system didn't come to an abrupt end at the end of World War II. As we know, it continued. Some countries, like India and Pakistan, obviously were created, but many countries only got independence in the 60s. So very early on, a group of people came to deliver healthcare in poor countries that actually were colonies. And those countries had not been receiving good care. So there was just to make, in a broad brushstroke, there was a lot of continuation of the policies. And there's many people who have written about this. Christian McMillan wrote a book on TB, and it's fascinating because he goes through He goes in depth into the archives of different countries, and he shows how in the 1950s, even when people knew that isoniazid monotherapy was dangerous, that you had to give combination drugs, the WHO recommended for poor countries that they give only monotherapy. And even the British doctors of Kenya were so up in arms, so angry about it, that they refused to give it. He outlines why preventive therapy hasn't been given, and it's just fascinating. When Comstock presented his data in 1964, the WHO expert committee said that cost, logistical difficulties, and likelihood of default and other concerns made it unfeasible for poor countries. They met again in 1974, the same thing. They said to try and use isoniazid prophylaxis therapy in poor countries was irrational. They met again with a different group called the International Union Against Tuberculosis and Lung Disease, based in Paris, in 1982. And they said, in practice, IPT has no role in developing countries. So it really was never about science, and I think that's been laid out. It really was about what people thought that developing countries could and should do. So in 1978, there was a little bit of a change. People thought, well, everyone should have access to health care. And Halfdan Mahler, you see two people in that picture. One is Senator Kennedy from the United States, who was a big proponent of health in poor countries. And beside him is Halfdan Mahler, the WHO Director General. They were pushing for there to be universal access to primary health care. And you all know, of course, about the Motta Declaration. These are pictures of Motta. There was what is not known is that there was a very big fight about Motta. Should it say that people should have access to the care they can afford, or should it say they should have access to the minimal care, the minimal level of care? And they ultimately decided that people should have access to a basic level of care. No new technologies, but what was available, to give basic care to people. So for many people who were health activists at the time, some thought this was a victory, but those that really wanted access to good care thought that this was actually terrible, because it meant that people in poor countries would get relegated to a lower level of care. You would get relegated to care based on your place in the global economy and not your place in the hierarchy of need, right? And so this was in some ways a scandal to some people, but there was an even bigger scandal. A group of people led by the Rockefeller Foundation got together right after this and said, there's no way we can do primary health care. They met at the Rockefeller Foundation resort in Bellagio, Italy. And the group discussed, well, there's not enough money to do primary health care. We should do selective primary health care and just focus on diseases that are going to kill a lot of people and that are easy to cure. So they focused really on vaccine-preventable diseases. And interestingly, for TB, they said diseases like TB shouldn't even be on the agenda because they're too complicated to treat and we need to do more research. The World Bank was in the room, UNICEF, all the different, the big partners. And so they all adopted this, and TB fell off the agenda for the 1980s. Now, I don't have time to go into it, but for various reasons around cost effectiveness, most notably that TB drugs like rifampicin went off patent, TB became cost effective to treat if you did it in a very programmatic way. And the WHO declared a global emergency in 1993 and created something called DOTS to treat TB. And that's something you have probably heard of because people do it in Pakistan. And it totally fit within this paradigm of selective primary health care. Easy, cheap, low, very simple so that you didn't need health workers. And they created this package. And basically, the package ignored almost everything that we had learned about. Search for people? No. Said not to search for people. Start therapy quickly? No. If you thought they had first-line disease, maybe, but there would be this long process to get them enrolled. Treat all contexts that don't have the disease? No. The only thing it did was that it encouraged patient supports. So that's why we're here. Now, let me get to the crux of the talk, which is in the next 5 or 7 minutes, is the how do you take what we've learned, stop the TB epidemic, and really use that as a wedge to build up systems of primary health care? I mean, that's really why we're here today. So we figured out that, our group had been working on MDR-TB, drug-resistant TB, for a long time, and we realized that the system, was full of rot. But we had focused so much on MDR-TB that we weren't looking at all these issues around isoniazid prophylaxis and other things. And when we did, we realized that the entire TB control strategy was completely wrong, and we realized that it was really based on national origin, and to some degree race, and to a great degree poverty. And so we thought, well, look, if we can see this, there's people way more experienced than we are that can see this. So we brought together a group. We created this meeting around the idea of aspiring to zero TB deaths. We were scared to talk about elimination. We thought that was just too out there. And we brought together people to a meeting in Cambridge, Massachusetts, at Harvard's main campus. And we said, why are we not able to do what other countries have done? Like, we looked at all these data, we looked at all this stuff, why can't we do it? And they said, you're not using the right epidemic control strategy. And we said, what would that be? And they said, you have to do active case finding, treatment of all forms of TB, treatment of latent TB, and patient supports. This is the same people that are drivers of the global system. So we were like, oh my God, they know. It's not just us. And then we thought, well, part of the problem is that they're part of the system that works through, top down. And so we said, well, how would we do this? And the same group of people told us, you have to have a different unit of political intervention. You have to work through effective public and private paths. And we thought, wow, that must be code word for not doing whatever they're doing. So we created a declaration out of this meeting, and 500 people signed it. And then we went to a pharmaceutical company, Janssen Pharmaceuticals, and told them that we wanted to completely change the paradigm around TB. And they gave us money to convene people to create a series in the Lancet on how to eliminate TB. And this series laid out exactly what I've shown you. It showed that if you did active case finding in households, you'd find 1 to 5% of TB cases in the households. 1,000 to 5,000 per 100,000. If you looked at hospitals, you'd find 5 to 10%, 5,000 to 10,000 per 100,000. The series put out all the arguments of why you had to do prophylactic therapy. It showed that right now we focus on that little tiny dot in the corner of smear positive cases, but we should be looking at all those people that are infected, that big square of 5 to 10%. And then we found out that our colleagues at the WHO, Philippe Glazieux, Chris Dye, Mario Raviglione, they actually had published papers saying that you should, if you just treated active cases, you'd see a drop, but if you treated active cases and latent TB, you'd see this massive drop. And then we found out that the WHO was actually advocating this for rich countries. And their website said, if you are a poor, lower middle income country, or your TB rates are high, press this link. And then when you press the link, it took you to another site that said not to do any of this. So we were just like, oh my God. We were stunned, right? So what we thought is, why don't we put this together into a package? We took the Lancet series data and we said, it's simple: search, treat, and prevent. Search actively, test properly, treat effectively, support people through treatment, and prevent through infection control, prevent exposure, and treat exposure. Then we got to, how do you operationalize this? And Aamir here had been telling me for ages, Karachi, Asian megacity, we've got to think about megacities, etc. And it was really interesting because when we started doing anthropological work to look at how social movements had succeeded, what they had done, like look at recycling or getting bike lanes in countries. It all started in municipalities, it started in cities. And so we said, okay, let's create a whole new strategy. Let's have one area of moral clarity that's going to drive us. And this is important because this is the moral clarity that drives Indus Hospital. And that is that health is a human right, and people who are poor or vulnerable are not a different species. So we shouldn't be giving them different care. And then the second area of moral clarity is that we decided we're not going to lend our voices through commission or omission to different standards of health for people based on their race, religion, class, sexuality, gender, or national origin. And that means that if you happen to be in Pakistan or in Papua New Guinea or in Boston, you should be getting the same care, unless there's a reason you shouldn't, a physical reason. And we said, let's bypass these systems that are blocking us at the country level and go to cities. And we realized that cities are incubators for learning. They have their own money. They produce a large part of the world's GDP. And if you look at, 60% of the cases of TB are just in 6 countries. And if you look at the urban populations of those countries, it's quite big. And so we created something called the Zero TB Cities Project. And it was started by Harvard, the Stop TB Partnership, IRD, and Partners in Health. And then we later started calling it the Zero TB Initiative, because it involved more than cities. And then we created an NGO called Advanced Access and Delivery to be the secretariat for that. And it basically, this is a busy slide, you can't possibly see it from where you are, but it basically said there's 3 components. Use the comprehensive program, search, treat, and prevent. Target households and places where patients seek care, and target municipalities to start programs and learn how to do it. And you create a platform for high quality community-based delivery of DR TB and regular TB. Really simple. And then we use this. We had a project in Tomsk in the Russian Federation, and TB rates were 120. Doing this exact program, we dropped the rates in half to 60. We went to another province called Voronezh, which is about 1.5 million people. The rates of TB were 69. We did this exact thing. It dropped to less than 15. So we know this works. There's no magic here. So now the synergy with universal healthcare. When you think about universal healthcare, you start to realize that there's a lot of diseases that people have that have very similar trajectories as TB. You have to diagnose the people. And this is a graphic looking at compliance for oncology, breast cancer drugs, diabetes, cardiovascular disease, asthma, etc. And you can see there's a similar feature in all these diseases. If people can get diagnosed, if they can get treatment, there's a drop-off in their ability to finish treatment, which we refer to as compliance. And so we realized that if you can create this platform to get to the communities where patients live, if you can link the clinic to the communities where patients live, using TB as an entry wedge, you actually can prevent things like blindness, wound infections, and dialysis. And when you start to think about it, when we started going to cities, we first went to Chennai in India, and basically when we spoke to the commissioner at Chennai, he said, "Oh, I love your TB idea, but that's not my biggest problem, right?" And we were like, "Yeah, what is your biggest problem?" And he said, "Diabetes. It's 13% in our urban poor, amongst our urban poor. That's 13,000 per 100,000. And their TB rate is 250 per 100,000. So we said, "How are you doing with that?" And he said, "We're not getting any of them." And so we said, "What if you started at 250 and built up to 13,000? And he said, "That would be great." So we want to use this as a platform to do more, so that you don't end up with the catastrophe of a bunch of people without legs who are blind and need dialysis. So basically, this is where this platform for TB becomes a platform for 21st century medicine, where you can treat diabetes, COPD, heart disease, and mental health. And then you have to, once you start trying to do this in the community, you have to be thinking, oh, we can't treat millions of people by going to their house every day. And you start to talk about the technologies that I think Aamir is going to talk about in a few minutes, and really thinking seriously about the future of medicine, which is how to deliver care across the spectrum. So I want to thank everyone again for the time. I can't think of a better place to be talking about this than Indus Hospital, because I think what Indus is doing with Zero TB Karachi, which is the first truly implemented Zero TB project, is going to revolutionize the way we're thinking about TB. But our hope is that people will realize, and I know Indus realizes this, that people do not live in hospitals. And if you have a lot of the diseases that we've just mentioned, you shouldn't be in a hospital. If you are in a hospital, something bad's happened. And the hospital should really be the hub of a systematic way of, a system of spokes that can keep people on care. So thank you very much.
Thank you, Dr. Salman. I would like to call our second speaker for his talk, Dr. Aamir. Dr.